Hey everyone and welcome back to the channel. Just in case you're new around here, my name is Khaled and I'm a final year medical student. In this video, we're going to be covering cardiovascular embryology, specifically embryological derivatives, heart morphogenesis, and the fetal heart circulation. At around 3 weeks of gestation, the heart tube begins to form. This is a figure of that sort of heart tube, which ends up convoluting over itself to form the actual heart and associated vessels. In this figure, we have one label missing, which is the truncus arteriosus, which is going to be slightly superior to the bulbus cordis. The truncus arteriosus, I use the name to remind me, so it's the arterial trunks. The main arterial trunks are going to be your ascending aorta and pulmonary trunk. The bulbus cordis is going to give rise to the smooth parts of the left and right ventricles. And since we have smooth parts, then we're going to have rougher parts to the left and right ventricles, which are going to be given by the primitive ventricle. Trabeculated in this sense just means the rough parts of the left and right ventricles. For the primitive atrium, it'll give the rough parts of the left and right atria. And since there are trabeculated portions of the left and right atria, then there are also smooth parts. The smooth part of the right atrium comes from the right horn of the sinus venosus, the right horn of the sinus venosus, while the pulmonary veins are what give the smooth part of the left atrium. It's usually very common for students to make a mistake that the left horn of the sinus venosus is what gives the smooth part of the left atrium. However, the smooth part of the left atrium is actually part of the pulmonary veins. They get absorbed into the left atrium and they form the smooth part of the left atrium. Lastly, we have the endocardial cushion, which I always like to explain is a structure that fills in the gap. So when we talk about the atrial septum, when we talk about the interventricular septum, you're going to notice that there are some structures that are left out, and the endocardial cushions basically come in and fill those gaps. They also give rise to the valves, and this includes all valves, the mitral, tricuspid, as well as the semilunar valves, the aortic and pulmonary. When it comes to the cardinal veins, it's important to recognize that there are numerous vessels coming out of the sinus venosus. They could be vitelline, they could be umbilical, so on and so forth. The ones that I want to really draw attention towards are the cardinal veins, specifically this right anterior cardinal vein as well as the right common cardinal vein. They're going to form your superior vena cava, and you can sort of picture it. This will be eventually your jugular. This will be another jugular. This will be the brachiocephalic vein. The inferior vena cava will come instead from the right posterior cardinal vein. There are also other anastomotic veins, for example, subcardinal and supracardinal, which also contribute to the formation of the inferior vena cava. So this is all mainly memorization. Now, how would you get a question that asks you about this? Well, they try to relate it to the anatomy. So they would give you, for example, a CT image, and they would tell you with an arrow that they're interested in this structure. Then they ask you what is the highlighted structure's embryological derivative, and they give you several choices. In this case, this is the superior vena cava, so the answer would be exactly, you guessed it, it's A. Now, at some point throughout gestation, namely week 4, the heart begins to undergo a process known as cardiac looping. This is when the heart actually eventually ends up being in the left side. Now, in this image, it failed to undergo that process, and for that reason, the heart's actually on the opposite side. So this process mainly requires both cilia and dynin. Cilia is mainly responsible for motility. Sometimes it brushes pathogens out of your respiratory tract, so on and so forth. While dynin, for instance, what it does is it helps, for example, if we have a cell here, and this cell, for example, has this long axon of a neuron, its job is bringing things back to the cell. So it's sort of a retrograde intracellular transport. So any defect in dynin can actually lead to dextrocardia. This can be seen in Cardiac syndrome, which is basically a part of primary ciliary dyskinesia. That's where actually a lot of the portions in the body that require cilia are not going to be working as well as they should be. For example, they get respiratory infections because they're unable to clear a lot of the gunk that's within their respiratory tract. This is something that we'll cover in more detail, possibly in the genetics in the future. When it comes to the formation of the atrial septum, it's a rather simple process. What ends up happening is we need to close this gap between the right atrium and the left atrium. This gap is termed as foramen primum. So foramen means hole, and primum refers to the first. So the first hole here between the right atrium and left atrium is this big gap between them. So what ends up happening is we send down a septum. Now, the issue with this is that this septum can't actually reach all the way. It's going to have a hole develop in the middle of it. So as it's going down, a hole will develop in the middle of it, and we term that hole as foramen secundum. So it's the second hole, and it's within septum primum. So now what ends up happening is we actually develop a second septum to cover that hole. And what ends up happening is we develop a flap where blood, if the pressure is high enough within the right atrium, blood can push against this flap and actually reach into the left atrium. This is actually important for the fetal heart circulation, as at this point, we do want blood going from the right atrium into the left atrium. Now at birth, what ends up happening is these two flaps will actually fuse. If they don't fuse, they get a disease known as patent foramen ovale. If there was any problem with the formation of the septum, for example, they were not able to form septum secundum, then you would have a defect within the atrial septum. And a defect is not the same as patent form and ovale. So patent form and ovale, you would have these two flaps against each other, but they didn't fuse, so you can very easily push one side to sneak blood into the other chamber. However, with atrial septal defects, they actually have a full-on hole, a full-on defect between the two chambers where blood can easily pass through. Now, the issue with this, the clinical relevance of this, is that if a patient has, for example, blood clots in his leg and they travel to the inferior vena cava, then they go into the right atrium, they can actually traverse this specific defect, or they can actually traverse between these two flaps, and they can reach the left side of the circulation, leading to systemic circulation, leading to actual strokes or blood clots within the systemic circulation. This is termed as paradoxical thrombi because you expect these blood clots to actually go to the lungs. That's a disease known as pulmonary embolism. But the reason that they don't go there is because of these defects, so it causes a paradoxical situation where clots in the venous system are traveling to the systemic circulation without traveling to the lungs. We'll talk more in detail about congenital heart diseases in a separate video. I just wanted to mention it here so that there is some correlation between the embryology that we're learning and the pathology. When it comes to the ventricular septum, it's even easier. We're going to have part of the muscle of the right ventricle and left ventricle grow upwards to form the muscular portion of the septum, and then part of the actual aorticopulmonary septum, which is actually just, if you imagine this is the aorta and this is the pulmonary, this septum between them, as it's twisting and fusing, it's going to reach down and form the membranous part of the interventricular septum. Usually all these septums that we talked about, they don't actually reach all the way down. They don't actually reach all the way through. So what ends up happening is you have these endocardial cushions which actually fill the cracks. So anything left, you would have, for example, the endocardial cushions come in and sort of fill all these cracks. This actually explains why patients, for example, with Down syndrome who have endocardial cushion defects would actually develop, for example, a VSD, because part of your interventricular septum is due to endocardial cushion. So if you have a defect in them, you're going to have VSD. Now, most of the VSDs that actually occur in this membranous section. One really important point about the aorticopulmonary septum is its embryological derivative, which are neural crest cells. So neural crest cells don't actually only give rise to neural tissue, but also several other tissues that we'll talk about when we get to their respective sections. In this case, you have to know that the aorticopulmonary septum is actually composed of neural crest cells. That's its embryological derivative. When it comes to the blood that's going to the fetus, it is important to be aware of the several shunts present within the fetal heart circulation. So we're going to start here at the placenta, and the baby is going to get oxygenated blood from the umbilical vein. So even though it says vein, it's actually filled with oxygenated blood, and this is because vein doesn't mean that the blood should be deoxygenated. It just means that it is a vessel going to the heart. So in this case, although it's a vessel going to the heart, it's actually carrying oxygenated blood. So it's going to have to pass across the liver, so it's going to get passed over the liver through ductus venosus. The reason this happens is because the mother's liver actually already does all the metabolic processes that is necessary for the fetus, so he doesn't have to really delay himself with the blood. He doesn't have to pass it through his own liver. Instead, he can just rely on the metabolic pathways of the mother's liver. So then it's going to reach the right atrium through the inferior vena cava of the baby. Within the right atrium, part of the blood will go in the right ventricle, and most of it will go through this foramen ovale, which is not a disease process. It is something that's supposed to happen in order to allow blood to go from the right side of the heart, which goes to the lungs, all the way over to the left side of the heart and the left atrium. So the majority of the blood will go into the left atrium because the pressure here is going to be more than the pressure in the left atrium, but some blood will go into the right ventricle. Now, this is our second shunt, the patent foramen ovale. But what about the blood that goes into the right ventricle? Well, as it gets pushed into the pulmonary artery and the pulmonary trunk, you'll notice there's this extra shunt here. This is called ductus arteriosus. And we'll talk a lot about ductus arteriosus and what can go wrong with it, but in this case, you just have to know that it's the shunt that's preventing blood from going all the way to the lungs and instead giving it a direct route into the aorta. So this is how blood goes all the way from the placenta all the way to the aorta of the baby to feed all his important organs. After that, the blood gets thrown back into the umbilical arteries where they get to carry deoxygenated blood back into the placenta so that the mother can take it back and replace it with oxygenated blood for the fetus. Alright, so now we erased all the ink on the slide. I would just like to mention a few more principles to tie in some other important concepts when it comes to pulmonology. So in this case, why don't we send the blood to the lungs? Well, it's mainly for two reasons. One, the blood is already oxygenated, so we can just send it directly to the left side of the heart for the systemic circulation. But the other reason is because the lungs are filled with amniotic fluid, so they don't really have that much oxygen. Now, the lungs are interesting and they behave sort of differently to the rest of the body. You see, there's something really interesting about the lungs when you compare them with different tissues. So these are the tissues of the body, while on the left side we have the lungs. Now, if the lungs experience low oxygen, what they end up doing is actually vasoconstrict. But with tissues, if they experience low oxygen, they actually want to vasodilate their arteries. Now, this really makes sense, and it's mainly because the lungs are what give oxygen to the vessels. So if there's not really good oxygen in the lungs, they'll want to shunt that portion of the lung to other areas. So for example, if this area of the lungs are not receiving that much oxygen, then they'll want to vasoconstrict the vessels here so that it can go to other areas which have better oxygen. But with tissues, for example, if you have some skeletal muscle that needs some oxygen and it has low oxygen, it's going to vasodilate so that more blood reaches it and subsequently more oxygen reaches it. In this case, both fetal lungs actually have no oxygen. So you have a lot of vasoconstriction there. For that reason, there is a lot of buildup of pressure against the pulmonary artery. So this kind of explains where this extra pressure in the right atrium is coming from. Of course, the amount of blood reaching the right atrium is a lot, but at the end of the day, these lungs are also contributing significantly to it. So this is termed as pulmonary vascular resistance. And pulmonary vascular resistance of the baby is actually increased because there's no oxygen within the lungs. The second the baby actually is born, that's when pulmonary vascular resistance goes down. Another important note is that notice how the blood in the aorta, it doesn't really have any problems with sending that blood from the umbilical arteries into the placenta. The placenta provides low resistance against flow, which makes sense. You don't want blood building up within the system. You want blood to very easily go out so that it can be replaced with fresh oxygenated blood. So this actually explains how the aorta in this sense actually has much less pressure than the pulmonary artery. So with this high pulmonary vascular resistance and this low systemic vascular resistance due to the placenta easily favoring the blood flow from the umbilical arteries, you create the situation where the aorta actually has less pressure than the pulmonary artery, where the right atrium has less pressure than the left atrium. So all of this favors the shunts of the foramen ovale as well as the ductus arteriosus. However, when the baby is born, now things are different. Well, the lungs, for example, have more oxygen, so their arteries would actually vasodilate. And because of this, pulmonary vascular resistance actually goes down. Recall that the placenta was actually favoring this low resistance to actually take blood and replace it with new blood. However, now, since the baby can breathe for himself and provide his own oxygenated blood, we don't need that anymore, so actually systemic vascular resistance goes up due to the loss of the placenta. So now, due to the rise in pressure in the aorta, as well as the decrease in pressure of the pulmonary trunks, now the right atrial pressure actually decreases to a point where this shunt is actually not really favored. Instead, the left atrium has more pressure than the right atrium, and therefore, if there was, for example, any defect, blood would be favored to go into the right side of the heart. It's really important to be able to understand why these pressures change the way they do, because they do love to ask about them. And in my opinion, understanding them goes a long way to being able to confidently answer these questions instead of just memorizing that the right atrial pressure decreases, left atrial pressure increases, systemic vascular resistance increases, and pulmonary vascular resistance decreases. Now, lastly, I'd like to talk about this ductus arteriosus, mainly what keeps it open or closed. Now, in the fetus heart, when the baby is within the mom, what ends up happening is, due to the low oxygen within the arterial system, as well as the prostaglandins that are being secreted by the placenta, namely prostaglandin E2, this ductus arteriosus is going to stay open. The prostaglandins signal to the ductus arteriosus that this is still a fetus that requires this shunt, and the low oxygen within the arterial system is proof of that, because, well, it is proof that we still need this shunt to send oxygenated blood into the arterial system. However, when the baby is born, there is enough oxygen within the arterial system that this shunt is no longer needed. Moreover, due to the loss of the placenta, you actually have less prostaglandin E2. And when you have less of prostaglandin E2, it favors the closure of this ductus arteriosus. Now, sometimes, in some rare instances, this ductus arteriosus could remain patent. Now, when that happens, we give the term PDA, and that stands for patent ductus arteriosus. So when this pathology occurs, you can actually use NSAIDs to be able to decrease the amount of prostaglandins. Recall that they actually work on COX-2, and this would eventually decrease prostaglandins, and this would promote the closure of the PDA. However, it's very important for you to realize that sometimes some babies are actually going to require this to stay open. So don't always be quick to try and close it, because sometimes their survival depends on it. If you found this video beneficial, then please consider liking and subscribing, as it motivates me and supports me to make all of these educational videos for all of you. As always, thank you for watching, and I'll see you in the next one.